Good afternoon. It is Wednesday, July the 15th, and I am obviously not Gary McLeod. Gary's out. I am just your friendly neighborhood CMO, Peter Valenzuela, and I'm here with Dr. Gary Green for another Q&A session. And I know it's been a little while since we've done this, so we wanted to really give you a few updates on what's changed. So Gary, anything new with the virus?
Hi Peter, nice to be here today. Hello everyone. We are tracking the virus internationally, and we've seen that, as expected, different subtypes of the virus are evolving. And we've been following a clade, so a subtype of the virus is called a clade. There's a new clade that first showed up in Europe, and then we're seeing it in the United States, more on the East Coast and on the West Coast, and maybe even more in Southern California than Northern California. It's called the G614 clade. A single amino acid substitution in the spike of the virus has allowed this new clade to emerge more than the older clade that came out of China. Is that important? We think that this new clade has more transmission, so it's slightly more contagious. But the good news is it's not more dangerous, it's not more virulent, it doesn't have a different disease manifestation. So we think that a new clade, on top of other reasons where people are not socially distancing and not following public health guidelines, not wearing masks, this is contributing to why we're seeing increasing cases in certain areas of the world.
Now, Gary, I've been reading something about the clinical disease and blood type and how that might play a factor. Is there anything to that you've studied or read about?
Yeah, there's been a couple of studies out of Spain and I think Italy that have talked about blood types, maybe one out of France. And what happens is that in early disease, in early studies, we try and determine what are risk factors. Like we know about age, we know about diabetes, we know about heart disease. And so people have compiled these cohorts and looked to see who's surviving, who's not surviving, and why. And one of the things that fell out of that in a retrospective study, in two retrospective studies, is that the A blood type, so A plus or A minus blood type, those patients seem to have a more severe course of disease. Where the O blood type, O positive and O negative, that's a better course of disease. Now in the hospital, right now currently, with our adequate supply of plasma, everyone gets plasma treatment in the hospital. And that's important because in plasma treatment, we determine what the blood type is. We are not doing blood types to see who's going to have a severe course or who's going to have a mild course. It's just one of the pieces we put into CRPs, D-dimers, age, CT scan changes. It's one of the clinical pieces we look to see who may have a more severe course of disease, but we're not making treatment decisions based on that. Now, some providers are getting questions from patients, asking them, should I get my blood type? It's not really necessary because we're not going to do anything differently. Johns Hopkins is studying plasma treatment in the outpatient setting, and they may integrate that data into outpatient treatment, but we're not doing that yet as well.
Yeah. So Gary, I'm going to ask you a question that my wife's asked me about, and I'm sure there's other people out there who have pets. We recently adopted a cat from our neighborhood who we really enjoyed. She's inside with us, and the big question is, can pets get this infection as well?
Yeah, this is Snowy, right?
Zoe
the cat. So that's a good question. I've got a few questions from other docs as well. There is data, mainly from the CDC, that shows out of New York that animals do get infected with this. Now we know this is a zoonotic disease, which means this came from animals. So we think that this came from a bat. But we also know that humans can infect animals. And cats, guinea pigs, and ferrets seem to be the most susceptible to this so far. In fact, there was a couple large cats in the New York Zoo that got infected. But as it looks, we can infect the cats and the guinea pigs and the ferrets, but they can't infect us. So it doesn't go both ways, and that's very important, because like influenza, that's when the mixing happens. And you don't want that mixing to develop a new novel virus. Dogs and farm animals and birds do not seem to be as susceptible to this virus. So that's important because with influenza, we follow that as bird flu and pig flu, and we see influenza mixes in a different animal population. This virus doesn't seem to mix, but our cats, guinea pigs, and ferrets are susceptible to our infection. The other interesting point about that is the guinea pig and the ferret may be a good animal model for this. So when we study drugs, study vaccine, study serologic responses, we may use those animals to study how the virus is doing.
Yeah. Good, thanks for letting me know. So a lot of our physicians and clinicians are starting to get messages from patients saying, I don't have any symptoms, but there's somebody at work who tested positive for COVID, or somebody in my family has tested positive for COVID. Should those patients be getting tested or not at this point?
Yeah, this is a major question. This is the asymptomatic population who has a close contact at work or at home, and should they be tested, or can we test them? Well, the best answer is, if resources were available, is they should be tested. We should test symptomatic folks, we should test contacts of symptomatic folks, and we should be testing those at high risk. The problem is we don't have that capability. So right now, not only in California, but in other states feeling this this increase in viral transmission, just like New York had the problem about a month ago, is that we don't have the testing capability to test everyone. And so what we're doing is we're trying to prioritize the testing for those that need it the most, and then give advice to patients as best we can who are asymptomatic. So I want to show you guys a couple things. One is I'm going to show you a couple slides. The first slide is an epi curve of Sonoma County.
Okay.
This is how we're doing. So if you look at the very top of this slide, you can see that Sonoma County, we've had 1,900 cases. We've done 62,000 tests. This is all hospitals and clinics together with public health. That's a testing rate of 3.1%. And as you look at the epi curve to the right, where the black arrow is, that's telling you that we haven't hit the peak yet. Sonoma County has been able to flatten the curve under Dr. Mays' great leadership, but we still haven't seen the peak yet. So there's still transmission happening. Now, how does that compare to Sutter? So for our respiratory care clinic, we, thanks to Sean Franklin's data, we have done more than almost 4,000 tests. Wow. So 3,800 tests at our respiratory care clinic. And our testing rate overall was sitting about 1.8%. In the last 2 weeks.
Is that the positivity rate?
Yeah,
okay.
Our positive testing rate. So 1.8% of people overall have tested positive. If you look in the last couple weeks, our testing rate's gone up to 2.1%. So we're at 2.1%. The shared lab for Sutter Baywide is at 6.8%.
Yeah.
So we have flattened the curve, but we're seeing a lot more cases in the community and in the hospital. So we're not at surge, but we're also not at the peak yet. So we need to develop very clear guidelines on who gets tested and how do we use this testing capability in a judicious manner. So the second slide I'm going to show you, this is a slide that kind of reviews the respiratory care clinic, and there are two pathways for our respiratory care clinic. There's a symptomatic pathway. When patients have symptoms, they should be tested, and these patients see a provider. The provider assesses them with vital signs, and then testing is done. The second part of the pathway is a testing-only pathway, and these are asymptomatic high-risk groups, and they only get testing only because they have no symptoms, but we want to make sure that these patients that we understand their risk of getting an infection or in the incubation phase. So
sure.
The patients who get this, all hospital patients, even if you don't have COVID symptoms, get tested. Anyone who's having elective surgery needs to be tested, or any surgery at all, or even conscious sedation for colonoscopy. The reason is we know that for incubating patients that are not tested and then in the post-op period get COVID illness, those patients have a higher mortality. In one study, up to 20% in China. So we want to make sure that preoperative and pre-procedural patients get tested. We also want to test patients who have acute on chronic conditions. So their emphysema or their asthma or their heart failure is flaring, and the doc needs to know, is this COVID or is this their chronic condition? So acute on chronic condition patients are getting tested. We're testing newborns of positive mothers, and that's mainly in the hospital. And very importantly, we're testing symptomatic patients who previously were assessed by a provider by video or phone, but now we think they may have COVID symptoms. And so that's an important caveat. We've added that to the group, and that's why that in your slide is at the very bottom in red.
Yeah, and my understanding is by doing this, that actually helps offload the providers in the respiratory care clinic, because these have already been seen via video or phone, and they're just sent to the LVNs for swab. Is that right?
That's right. Yeah, we're trying not to swamp the physicians and the nurse practitioners and the PAs that are doing the clinical assessment.
Sure.
And so this is a very quick testing only, so the doc gets the information back and can reconnect with the patient.
Great.
So these efficiencies are important because a respiratory care clinic is seeing a lot of patients and a lot of numbers, and we don't want to delay the testing.
Yeah.
If we test all of these asymptomatic contacts, we're going to push the numbers back in the respiratory care clinic, and surgery is going to be canceled. Patients are not going to have, that upper lobe mass, removed for cancer. That would be a survival thing. So I want to show you another slide. This is a slide that Gary McLeod has showed before, and we've updated this. This is a smart phrase, SMGR COVID asymptomatic testing. And this smart phrase is very important because it tells patients why we can't test them if they're asymptomatic and not at high risk, but it also gives them a couple options. Now, public health was doing some testing, but they're limiting their testing for certain outbreaks like in nursing homes, and they're only doing blood testing right now. But there is a site in Petaluma that you can do free testing, nasopharyngeal testing, and the website here is it's lhi.care/COVID testing. You can go to that site and you have to register to be tested. And then we also discovered another testing site, and LabCorp is doing testing called a Pixel test. We're not really sure how it performs, but for asymptomatic patients who are contacts, if they're really concerned about testing, they can go to the next slide, which is the website for Pixel. And here's a photograph of how it comes in the mail. Patients click on this site and they can order the Pixel test at home. This doesn't require a physician's order. This does not require an Epic order at all, but it is an out-of-pocket expense for patients. It's about $120. But this is for patients who need to be testing. And if you just give me a minute, I want to talk about other reasons patients will need to be tested. Some patients are like, my provider, my boss won't let me go back to work.
Yeah.
Other patients are telling us, hey, I just was traveling from New York or from Texas and I need to be tested, or I want to be tested because I just traveled from a highly endemic site. Other patients are saying, hey, I can't go back to college until I get testing. So a lot of physicians are getting a lot of requests for asymptomatic testing out of the high-risk conditions. And it's good to give our patients some of the options. When the shared lab is able to improve its capacity, and it's working on that, and when they do something called pool testing, we may be able to bring this in-house. Yeah. But right now, I think if we swamp the lab, then we're going to go beyond that surge capacity for testing.
Yeah. Well, Gary, thanks so much. As always, it's great to have you here. And hopefully Gary McLeod will be in on the next video. But until then, stay well, stay healthy, and thanks for watching.
Yeah, thank you very much, Peter.
Thanks.